Hi, so today we will discuss about the ampullary adenocarcinoma. So, as we know, CA pancreas. So, ampullary adenocarcinoma, uh, how the patient presents to us. So, if there is a clinical suspicious of ampullary neoplasm, we will do pancreatic protocol, CT abdomen, and pelvis. Esophagogastroduodenoscopy with side viewing endoscope with EUS with biopsy, and colonoscopy, if not done previously, perform according to the established guidelines. If the biopsy turned out benign, or it can be high grade dysplasia or adenocarcinoma confirmed. So what if the biopsy is benign or high grade dysplasia? Then what are we going to do next? Ampullary adenoma, if it is ampullary adenoma, then we will try to remove it endoscopically, and if margin negative, then we will keep the patient under endoscopic surveillance. But if it is positive margin, if it is margin positive resection, re-resection if feasible, then we'll do re-resection and then keep the patient under surveillance. But if not, then we will go for surgical ampullectomy. With ampullectomy, if margin is negative, then we'll keep the patient under endoscopic surveillance. But if not, if it is margin positive, still margin positive, then we would go for pancreaticoduodenectomy. Endoscopic surveillance is not required post pancreaticoduodenectomy. And if endoscopic removal is not possible, then we will go for pancreaticoduodenectomy. If the biopsy is adenocarcinoma, if it is adenocarcinoma, then we will do staging workup, that is CT scan of chest, pancreatic protocol, CT scan abdomen and pelvis. Then we will do liver function test, baseline CA19-9, CEA, endoscopic and consider for ERCP, endoscopic retrograde cholangiopancreatography or percutaneous transhepatic cholangiography as clinically indicated, and consider genetic testing for inherited mutation, and we will discuss this with our multidisciplinary consultants for further management. If there is no metastatic disease, consider MRI for intermediate liver lesion. Consider MRI for indeterminate liver lesions as clinically indicated, and histologic subtype pancreaticobiliary versus intestinal. So two things we have to see: MRI to rule out liver mets, and histological subtype whether it is pancreaticobiliary or intestinal type. And second thing, if it is metastatic, biopsy confirmation from a metastatic site, and consider molecular profiling of tumor tissue as clinically indicated. So if it is non-metastatic, we will do CT scan, chest, abdo-pelvis, pancreatic protocol, liver function, CA19-9, CEA, ERCP, stanting accordingly, and genetic testing and multidisciplinary consultation. If non-metastatic, do MRI for liver indeterminate lesions, histological subtype whether it is pancreaticobiliary or intestinal type. So if it is non-metastatic localized disease, then we'll proceed for surgery, which is the preferred option is pancreaticoduodenectomy and post-operatively adjuvant therapy according to the histological type. And if it is localized disease, consider neoadjuvant systemic therapy in patients with high risk features. Now what are the high risk features, we will see, and plus or minus subsequent chemo radiation, and consider biliary stanting if clinically indicated. Post neoadjuvant chemotherapy or chemoradiation, will do repeat CT or MRI, and if it is resectable, we will go for pancreaticoduodenectomy and then adjuvant treatment. If it is locally advanced, then treatment for metastatic disease. So high risk features include equivocal or indeterminate imaging finding, markedly elevated CA19-9, markedly elevated CEA, large primary tumor, large regional lymph node, excessive weight loss, extreme pain, and there is limited evidence of recommended specific neoadjuvant regimen of study, and practices vary with regard to the use of chemotherapy and chemoradiation. So if it is localized operable, we did pancreaticoduodenectomy. Now what all adjuvant therapies will give? So if resected, now we'll see stage. If it is stage 1, we'll give systemic therapy, or we can keep patient under observation. If it is stage 2, then we'll give systemic therapy with the subsequent chemoradiation or consider observation, and in case of stage 3, we'll give systemic therapy or subsequent chemoradiation. And surveillance every 3 to 6 months for first 2 years, then 6 to 12 months for up to 5 years. Surveillance will do history, physical examination, chest, CT or MRI, abdo-pelvis with contrast, CA 19.9. So initiation of adjuvant systemic therapy is recommended within 12 weeks. Initiation of systemic therapy, adjuvant systemic therapy recommended within 12 weeks of surgery if the patient is medically fit. Patient who have received neoadjuvant chemoradiation or chemotherapy may be candidate for additional chemotherapy following surgery and multidisciplinary review. The adjuvant therapy options are dependent on the response to neoadjuvant therapy and other clinical consideration. Total duration of systemic therapy is typically 6 months. So this is the management according to stage. Now what if it is resectable post neoadjuvant chemotherapy or chemoradiation? Now how will, so adjuvant therapy is same according to the stage, and will give adjuvant chemo or chemoradiation, or we can keep under observation in case of stage 1 and stage 2 disease. And if it is locally advanced, then treatment is according to the metastatic disease. So in case of metastatic disease, locally advanced unresectable, genetic testing for the inherited mutation if not previously done, and molecular profiling of the tumor tissue if not previously done. If it is good intermediate performance status of the patient, then we can give systemic therapy or targeted therapy based on molecular profiling as clinically indicated. Systemic therapy followed by radiotherapy for palliative indications, or systemic therapy followed by surgery or other locally directed therapies to liver or lung metastasis for selected patients with oligometastatic disease and response stable disease to systemic therapy. If it is poor performance status, if the patient is having poor performance status, then we will give patient palliative or best supportive care and consider systemic therapy or consider targeted therapy based on molecular profiling as clinically indicated or palliative radiotherapy. So what are the genetic testing inherited for inherited mutation recommended for patients with confirmed ampullary adenocarcinoma for or positive family history of cancer using comprehensive gene panel for hereditary cancer syndrome. So genetic counseling is recommended for patients with test positive for pathogenic mutation like ATM, BRCA1, 2, CDKN2A, MLH1, MSH2, MSH6, PALB2, PMS2, STK11, P53, or for patients with positive family history of cancer regardless of mutation status. Tumor or somatic molecular profiling, preferably using NGS assay, is recommended for patients with metastatic disease who are candidates for anti-cancer therapy to identify clinically actionable or emerging alterations if clinically indicated. And these alterations include but are not limited to fusions like ALK, NRG1, NTRK, ROS1, FGFR2, RAT, mutation like BRAF, BRCA1, 2, KRAS, PALB2, amplification of HER2, MSI, DMMR, TMB using comprehensive genomic profiling via FDA approved or validated NGS based assays, and HER2 overexpression via IHC or with FISH. So RNA sequencing assays are preferred for detecting RNA fusions because gene fusions are better detected by RNA based NGS. Testing on tumor tissue is preferred. However, cell free DNA testing can be considered if tumor tissue testing is not feasible. Good performance status is defined as ECOG 01 with good biliary drainage and adequate nutritional intake. Intermediate PS is ECOG 2, poor PS defined as ECOG 3. So, with all this treatment, if the disease is progressing and if performance status is good, we can keep the patient under clinical trial or systemic therapy, targeted therapy based on molecular profiling as indicated, or palliative therapy for severe pain refractory to analgesic therapy. Palliative and best supportive care or clinical trial. And in case of poor PS, we can keep patient under palliation, best supportive care, or we can give systemic therapy or targeted therapy based on molecular profiling as clinical indicator, or palliative radiotherapy.